Okay, let's unpack this. We are diving deep today into a really fascinating and, well, rapidly evolving area of medicine.
Absolutely.
You've shared some incredible sources with us, research papers, articles, all peeling back the layers on how heart surgery is changing.
Yeah, there's a lot there.
Think of this deep dive as your shortcut, really, getting you to the core of what's happening at the cutting edge without getting totally buried in the details.
Right. Distilling it down.
Our mission,
Huh.
to pull out the most important insights from all this material you've given us. We're focusing specifically on the rise of minimally invasive cardiac surgery.
From ICS, yeah.
We'll look at, where it came from, what's happening right now, the tech involved.
And what it means for the future.
Exactly. What it all means for treating heart conditions down the line. So yeah, get ready for some surprising facts, maybe some aha moments as we explore this.
Sounds good. The sources you provided give us a great place to start. They define minimally invasive cardiac surgery, or MICS, pretty broadly. Essentially, it's about using techniques that avoid that traditional big cut down the middle of the chest, the sternotomy.
Right, the one everyone pictured.
Yeah. Instead, they use smaller approaches. Could be a partial mini sternotomy or incisions on the side, thoracotomies. And often they're using video assistance, or even robotics now, to treat a whole range of conditions.
So like valves, bypasses.
Valves, bypasses, yeah. Even more complex stuff like aortic surgery, fixing atrial fibrillation, putting in devices.
So it's less about what you're fixing and more about how you get access.
That's a good way to put it, how you get there.
Where did this whole idea, this desire to avoid the big incision even start? Because for decades, that was just the way, wasn't it?
It absolutely was. The full median sternotomy became the standard really after the first successful open heart surgery using cardiopulmonary bypass, way back in 1953.
Gave surgeons great access, I suppose.
It did. Wide open view, very reliable, but the idea of doing it less invasively, well, that actually cropped up surprisingly early.
And really, how early are we talking?
The material points to some pioneering work as far back as 1967.
Wow, 67.
Yeah, Kolosov performed a coronary artery bypass a CABG, but on a beating heart and through a left thoracotomy, a cut on the side.
That sounds revolutionary for back then.
It really was. Then things really picked up speed in the early 1990s. Surgeons started pushing the envelope with the first series of minimally invasive direct coronary artery bypasses, mid-caps.
Mid-cap. Okay, that term definitely pops up a lot in these sources.
It does. Initially, they focused on getting to one specific artery, the left anterior descending, the LAD.
The big one.
The big one, yeah. Through a smaller side incision, that left mini thoracotomy.
What was the trickiest part about doing a bypass like that through such a small opening?
The biggest challenge, and the research really highlights this, was visualization and just precision.
I can imagine.
Trying to see and then stitch tiny coronary arteries through a limited view. It's incredibly difficult.
So the innovation wasn't just the smaller cut.
Not at all. It was also developing specialized tools. Unique retractors to hold things out of the way, stabilizers to keep the heart muscle steady right where you're grafting, even devices to gently lift and reposition the heart itself.
So technology was enabling this minimal approach right from the start.
Absolutely crucial. And the 90s saw techniques evolve even further. You started seeing port access methods.
Like keyhole surgery?
Kind of, yeah. And video-assisted surgery, VATS. And then robotics entered the picture.
Oh, robotics.
First used for really precise tasks, like harvesting the internal mammary artery that's a key vessel used in bypasses.
Okay.
And that eventually led to totally endoscopic coronary artery bypass, or TCAB.
TCAB. That sounds intense. Fully done through small ports, no main incision at all.
That's the idea. It can be done either on a beating heart or with the heart stopped using bypass.
Right.
And while it started with that main artery on the left, the LAD, the sources show, it's expanded now. They can target other vessels, even use arteries from both sides of the chest.
Okay, so what did the early results for these procedures, like mid-cab, actually tell us? Were they effective compared to the traditional open chest way?
The early data was actually quite compelling, especially for patients who just needed that single bypass, like for the LAD. Studies cited in the material showed really impressively low in-hospital mortality rates, sometimes close to zero, actually.
Wow.
And very high success rates for the graft staying open long-term, like 92 to 100% patency.
That's great.
But maybe the most striking thing was the recovery time.
Ah, yes.
The research indicates patients getting mid-cab often had significantly shorter hospital stays. We're talking days less.
Days.
And one study mentioned they returned to full physical activity 4 times faster than with traditional open surgery.
4 times faster. I mean, that immediately changes the whole patient experience, doesn't it?
It's a huge difference. Now, it's important to note, the sources do mention a small percentage of cases, maybe 2–3%, needed conversion to a full sternotomy during the procedure.
Okay, so sometimes they had to switch mid-surgery.
Right, but that rate was generally low in those early series.
Okay, let's pivot slightly. There's something called hybrid coronary revascularization, or HCR. The sources mention this. What's involved there?
Yeah, HCR. It's basically a strategic combination.
Okay.
It typically pairs a minimally invasive surgical bypass of that key left anterior descending artery, often using that durable Lima graft we just discussed.
Right, the mid-cab approach, maybe?
Potentially, yeah.
Yeah.
And it combines that with percutaneous coronary intervention, PCI, so balloons or stents.
Ah, so angioplasty for the other blockages?
Exactly, using stents to address blockages in the other coronary arteries.
So surgery for the main plumbing and stents for the branches, kind of?
That's a great analogy. The goal is to leverage the strengths of both worlds, get the best of both approaches.
And are the guidelines on board with this?
Well, guidelines from major cardiac societies do acknowledge HCR. They say it's an option that may be considered for certain patients.
May be considered. Sounds cautious.
It is, and usually in experienced centers.
Who are the sort of ideal candidates for this hybrid approach? What's the thinking?
It's often viewed as a more personalized strategy,
Hmm.
potentially good for higher-risk patients, where maybe a full open CABG is just too much stress.
Okay.
You get the proven long-term durability of that surgical imidalad graft,
Right.
while PCI offers a less invasive way to treat the other lesions. And the interim results from studies mentioned show pretty good graft patency and survival rates.
But it sounds like this is still a relatively newer area compared to, say, full CABG or just PCI alone.
It definitely is. The sources really emphasize that HTR is relatively new. We just don't have the same depth of large randomized controlled trials comparing it broadly to other strategies.
Not like we do for the traditional procedures.
Exactly. The existing studies, while they look promising, they vary quite a bit in how they're done, who they include. Makes it hard to draw really firm conclusions yet.
That makes sense. Okay, moving beyond the coronary arteries then. Minimally invasive techniques have also, well, revolutionized valve surgery, right? What's the story there?
Oh, absolutely. Minimally invasive valve surgery, or MIVS, has really taken off.
Yeah.
Pioneers were reporting on these techniques back in the mid to late 1990s. And the approaches vary quite a bit.
Oh, so?
You've got side incisions like a right lateral thoracotomy or smaller cuts in the sternum, partial sternotomies. And now you also have port access and fully robotic valve surgeries too.
So different routes to get to the valves, but all through smaller windows.
Precisely. And it requires, highly specialized tools, plus specific ways to manage the cardiopulmonary bypass, the heart-lung machine, during the procedure.
Right, you still often need the bypass machine.
Often, yes.
Right.
And for bypass in MIVS, surgeons can access the main blood vessels either centrally, through those smaller chest cuts, or peripherally.
Peripherally, like in the leg.
Typically through the femoral vessels in the groin or sometimes the jugular in the neck.
Are there pros and cons to accessing bypass peripherally versus centrally?
Yeah, that's a key point the sources highlight. While peripheral access, often through the femoral artery in the leg, is common, studies do indicate it might carry a slightly increased risk of neurological events, like stroke, especially in patients who already have vascular disease.
Okay.
Central cannulation, going through the chest, is often linked to a lower risk of strokes and fewer complications right at the access site.
So the choice depends on?
Often depends on the surgeon's experience, their comfort level, and importantly, the individual patient's anatomy and overall health.
Got it. What are the common incision types for MIVS then, specifically thinking about aortic versus mitral valves?
Okay, so for the aortic valve, which sits higher up, the most frequent approaches are either a partial upper mini sternotomy, that smaller cut on the top part of the breastbone,
Right.
or a right anterolateral thoracotomy, that's an incision between the ribs on the right side.
And for the mitral valve?
Mitral valve is usually accessed from the side. So typically a right anterolateral thoracotomy again, sometimes with video assistance.
Okay. And the big question, what do the studies say about outcomes? Comparing these minimally invasive valve approaches to the traditional full sternotomy.
Well, numerous studies and meta-analyses discussed in the sources point towards some significant advantages for MIVS.
Like what?
Things like faster recovery times, definitely shorter hospital stays, reduced need for blood transfusions,
Okay.
lower rates of certain complications like infection, and also new onset atrial fibrillation after surgery.
Mm-hmm.
And of course, better cosmetic results because the scar is smaller.
That makes intuitive sense.
Yeah. And some analyses even suggest a potential decrease in overall complications and maybe even mortality with MIVS, though it's important to say not all studies consistently show a mortality benefit.
Are there specific numbers that kind of jump out from the research?
There are. One large meta-analysis looking at aortic valve replacement noted a lower rate of that postoperative atrial fibrillation
Uh-huh.
and about a day shorter hospital stay for the MICS group compared to traditional surgery.
A full day less is significant.
It is. And another large analysis reported notably lower in-hospital and 30-day mortality, fewer kidney complications, fewer wound infections, and shorter ICU and hospital stays in patients who had minimally invasive aortic valve surgery compared to sternotomy.
Those are certainly compelling
They
benefits.
really are. However, the sources are quite careful to point out that these findings might be influenced by other factors, like how patients are selected for the procedure. Maybe healthier patients get MICS. And crucially, the surgeon's experience level. These are technically demanding surgeries.
Right, the learning curve.
Exactly. And the need for future large-scale randomized controlled trials is really highlighted to properly confirm these advantages definitively.
That makes sense. You need those big, well-designed studies. Okay, what about even more complex procedures, like surgery on the aortic root or the arch? Is MICS being used there too?
Yes, incredibly. It is that partial upper sternotomy approach we mentioned. It's been successfully applied to really challenging procedures involving the aortic root.
That's where the valve connects to the aorta, right?
Exactly. And even parts of the ascending aorta and the aortic arch itself, these are some of the biggest, most complex heart surgeries done.
Wow. So what do the early results look like for minimally invasive aortic surgery, or MIS?
Studies cited, including one with a 5-year follow-up, show shorter median hospital stays and fewer blood transfusions in the minimally invasive group compared to full sternotomy, specifically for ascending aorta and root surgery.
And long-term survival.
Comparable long-term survival in that study. Other research notes less postoperative pain and earlier discharge, too.
Okay.
And a meta-analysis suggested that maybe sternotomy patients had longer ICU and hospital stays and were more likely to need reoperation for bleeding or have kidney problems. While the major complications, like mortality and stroke, were actually similar between the MICS and sternotomy groups in that particular analysis.
So potentially a smoother recovery, better immediate post-op experience, but perhaps similar rates for the most serious complications.
That's what some of the current data seems to suggest, yeah. The sources also talk about some pioneering work using that partial upper sternotomy for aortic arch repair.
Even more complex.
Right, sometimes combined with less invasive endovascular methods for the descending aorta further down. The early results in these really complex cases report manageable complication rates, which is pretty impressive for such technically demanding stuff.
Again, really pushing the boundaries into very complex anatomy.
Exactly, but the sources are very clear. MIACE, especially for the arch, is still relatively early days.
Right?
It just lacks the large studies and the really extensive long-term follow-up that traditional aortic surgery has accumulated over decades. The early results are promising, but much more research is definitely needed.
Understood. Let's circle back to mitral valve surgery for a moment. The sources specifically mentioned robotic MIM views. How has robotics changed that particular field?
Yes, robotics. Systems like the Da Vinci system have been a major factor in advancing minimally invasive mitral valve surgery.
How so? What does the robot bring?
It offers significantly enhanced vision, often 3D high definition,
Better than just looking through a scope.
much better, and incredibly precise control of tiny instruments. Think wristed instruments that can move more freely than a human hand in a tight space.
Okay.
The first fully automated robotic mitral valve repair was actually reported back in 1998.
Wow, quite early.
Yeah, and robotics is now used for all sorts of mitral valve issues, repair, replacement, and it can even be combined with other procedures, like fixing the tricuspid valve or treating atrial fibrillation at the same time.
And what are the outcomes looking like for robotic MIMVs?
Well, one large study mentioned looked at over 1,200 robotic mitral valve surgeries. It showed very low rates of complications during the procedure itself and excellent results in terms of valve function afterwards.
That sounds positive.
Generally, yes. Meta-analyses tend to support the advantages of minimally invasive mitral valve surgery overall, including the robotic approaches when compared to sternotomy.
Same kinds of benefits. Shorter stays, less transfusion.
Exactly. Shorter hospital stays, reduced need for transfusions, better cosmetic results, Those themes keep coming up.
Did any studies show a clear mortality benefit with robotic or minimally invasive mitral valve surgery specifically?
That's a key question. While some observational studies have suggested lower mortality rates,
But
but the sources really emphasize that the large randomized controlled trials haven't consistently confirmed a mortality benefit that's specifically linked just to the minimally invasive approach itself.
so other factors might be at play.
Exactly. It
Right.
underscores again the importance of really rigorous study design and controlling for those other factors like patient selection and surgeon volume.
Makes sense. What about the tricuspid valve? You mentioned it briefly. It's often overlooked, but still crucial, right?
You're absolutely right. The forgotten valve sometimes it can be challenging. Minimally invasive tricuspid valve surgery, or MITVs, is often done alongside mitral procedures.
As a combined operation.
Right. Or sometimes as a standalone operation, usually via a mini thoracotomy, that side incision, again, with or without video or robotic help.
Is there much data comparing MITVs to traditional open tricuspid surgery?
The sources indicate there are still fairly limited studies here, and even fewer prospective randomized trials looking specifically at isolated tricuspid valve surgery done minimally invasively.
So still an emerging area?
Definitely. However, the data that is available does point towards potential reductions in complications, like needing a permanent pacemaker after surgery, less blood loss, and potentially lower mortality compared to the conventional open approach. But more research is needed.
Okay. And what if a patient needs work on multiple valves, like aortic and mitral?
Yeah, that happens. Some specialized centers are successfully performing double and even triple valve surgeries through minimally invasive approaches,
Triple valve. Wow. How?
usually using approaches like that partial upper sternotomy or limited right mini thoracotomy. The sources suggest that advancements in technology and surgical technique are making the operating conditions for these complex MICS procedures much more comparable to traditional open surgery.
And the results?
Early studies looking at multi-valve MICS are showing potentially superior results for things like wound healing and length of hospital stay compared to sternotomy. But again,
Complex, less common.
exactly. These are complex and still less commonly performed via minimal access, so the long-term outcomes are still being carefully documented.
Got it. So beyond just fixing the plumbing and the valves, the sources also touch on minimally invasive ways to treat atrial fibrillation and to implant LVADs. How is MICS changing those fields?
Right. For atrial fibrillation, or AFib, the surgical Cox-Maze procedure is the gold standard. It involves creating scar tissue lines to block those abnormal electrical pathways in the atria.
Okay.
That procedure has evolved too. Minimally invasive versions using video-assisted mini thoracotomy or robotics are now being performed,
Using different energy sources.
often using technologies like radiofrequency energy or cryoablation freezing to create those lesions. And research shows pretty good success rates in restoring normal heart rhythm.
Okay. And LVADs, those are the heart pumps, right?
Correct. Left ventricular assist devices, LVADs, essentially mechanical pumps to help failing hearts. Minimally invasive implantation techniques have emerged for these too.
Really? How long has that been around?
Well, the first attempts were actually decades ago, but they didn't really take off. The contemporary methods are much more refined, designed for today's smaller, more advanced pumps.
So how do they actually implant an LVAD through a small incision? It seems like a big device.
Well, the pumps are smaller now. The sources describe techniques where surgeons access just the tip of the left ventricle, the apex, and the main artery, the ascending aorta, through separate, smaller incisions.
Not one big opening.
Right. This might involve a limited mini sternotomy or combining small cuts on the sides of the chest. Sometimes this even allows two surgeons to work simultaneously on different parts, which can potentially speed things up.
Interesting. Can that be done without the heart-lung machine off pump?
Yes, minimally invasive LVAD implantation can be performed either with or without cardiopulmonary bypass. It's a point of discussion in the sources.
Pros and cons.
Doing it off pump has potential advantages, maybe less impact on blood composition, less inflammation,
Right.
but also risks. Potential instability if there's significant bleeding during the connection phase. Using bypass can help maintain stability during those critical moments.
Right. And how do the outcomes compare? Minimally invasive LVAD versus traditional open LVAD surgery.
The benefits noted in the sources for the minimally invasive approach include things like less bleeding, less severe right heart failure right after the operation.
Which can be a problem with LVADs.
It can be, yeah. Also, reduced need for blood transfusions and shorter time needed on the ventilator after surgery.
And major outcomes like survival.
A meta-analysis mentioned found no significant differences in short or midterm mortality. Neurological events like stroke or pump clotting between the minimally invasive and conventional techniques.
Okay, so similar major outcomes, but maybe a better recovery.
That seems to be the trend. And one key advantage, specifically for patients who might later be eligible for a heart transplant,
Yes.
is avoiding that full sternotomy up front for the LVAD. It makes the subsequent transplant surgery potentially less complicated because the chest hasn't been fully opened before.
Ah, that makes a lot of sense. Planning ahead.
Exactly.
It really sounds like technology is just a massive driver behind all of this MICS development. What are some of the emerging technologies the sources seem most excited about?
Robotics is definitely a major one, as we've already touched on with mitral valve surgery.
Right, the Da Vinci.
Systems like the latest Da Vinci offer incredible 3D vision that really enhances depth perception, which helps compensate for the surgeon not being able to directly feel the tissues, the lack of tactile feedback.
Okay, better eyes, basically.
Much better eyes. And features like, say, laser targeting for guidance and highly refined instrument control. They dramatically improve surgical precision in tight spaces.
Is it widely used now?
While it's still not universally adopted or available everywhere, these systems are expensive and require significant training. Robotics is fundamentally changing what's possible through minimal access.
And what about visualization tech beyond robotics? We heard about video assistants earlier, but the sources mention more, right?
Yeah, this is where things get really futuristic. Virtual reality, VR, and augmented reality, AR.
Ah, VR and AR in the operating room.
Potentially, yes. Beyond just looking at standard CT scans or echocardiograms before surgery, research is exploring how VR and AR could provide surgeons with enhanced imaging and real-time guidance during the actual procedure.
How would that work?
Well, VR can help surgeons visualize complex patient-specific anatomy in 3D before they even make a cut. They can use it to plan the exact placement of incisions or valve clips, maybe even simulate parts of the surgery and predict outcomes.
So really sophisticated pre-op planning using VRR and maybe overlaying vital info during the surgery itself, like a heads-up display.
Exactly that kind of idea. Overlaying critical anatomical information or instrument tracking onto the surgeon's view. It could help refine the surgical strategy, identify patients where MICS might be particularly challenging, and guide decisions during the operation itself.
Sounds amazing, but how far along is this?
Well, the sources are clear to caution that VR in cardiac surgery is very much still cutting edge. Most of the evidence comes from small, single-center studies so far.
So early days.
Very early days. We need much more rigorous research to really validate its widespread feasibility and prove its clinical impact.
Okay. Looking even further out, are there any other potentially game-changing technologies mentioned on the horizon?
The sources do touch upon the potential for integrating artificial intelligence.
AI. AI in surgery.
The idea is using AI to potentially optimize the entire surgical workflow from planning to guidance, maybe even analyzing outcomes. But of course, assuming its safety and effectiveness can be rigorously proven in clinical settings first, that's a big if.
Right. Safety first.
Absolutely. And that they also point to some exciting advancements in bioprinting.
Bioprinting, like printing tissues.
Potentially, yeah. The idea is maybe one day being able to create tailored tissue repairs, maybe patches or scaffolds, directly within the heart using fabricated biological constructs. But that's definitely further down the road.
Wow. Okay, so it's clear there are many really compelling advantages to MICS. Faster recovery, less pain, smaller scars, reduced complications like infection and bleeding in many cases seem common themes.
Yes, lots of positives reported.
But what are the potential trade-offs or the challenges that are highlighted in the sources? MICS isn't perfect, right?
No, absolutely not. Despite the benefits, MICS isn't without its own complexities. One thing that often comes up in meta-analyses is that minimally invasive procedures can sometimes require longer operative times.
Longer time in the OR.
Specifically, longer cross-clamp time.
That's when the aorta is clamped, stopping blood flow to the heart.
Exactly. It's necessary for precision in many valve or aortic procedures, but temporarily stopping blood flow to the heart muscle carries inherent risks. And also, potentially longer cardiopulmonary bypass time, the total time spent on the heart-lung machine.
Okay, so why is longer cross-clamp or bypass time a concern?
Well, the research has correlated longer cross-clamp times specifically with increased risks of certain complications after surgery, like low cardiac output syndrome or maybe kidney injury.
So potentially a quicker recovery overall, but sometimes a longer, perhaps slightly riskier time during the operation itself.
That seems to be a key trade-off noted frequently in the literature, yes.
Any other downsides mentioned?
Well, we touched on the complications that can arise from using peripheral access for bypass, like that slightly increased stroke risk
Yeah.
or local issues at the groin site, though central access can mitigate some of those. Another potential issue, less commonly reported but mentioned, is something called unilateral pulmonary edema fluid buildup in just one lung.
Hmm. Okay. And I imagine there must be a significant learning curve for surgeons transitioning from traditional open procedures to these minimal techniques.
Oh, absolutely. The sources strongly emphasize this point. Mastering MICS requires dedicated, extensive training and practice. It's not something you just pick up overnight.
Right.
Reducing that learning curve through structured training programs and continuous education is really vital for the wider, safe adoption of these techniques.
It really sounds like while minimally invasive cardiac surgery offers truly exciting advantages and is definitely expanding its reach,
It is, undoubtedly.
traditional sternotomy still remains the established benchmark, the gold standard for comparison.
For now, yes.
And more rigorous research, particularly those large randomized controlled trials we keep mentioning, is just crucial to fully understand the long-term outcomes and really validate these techniques across different types of patients in different hospitals.
That's exactly the picture painted by the sources, yes.
Yeah.
They consistently highlight the ongoing need for high-quality research to compare MICS and traditional surgery more definitively, looking not just at the immediate outcomes like hospital stay, but also potential subtle long-term differences, maybe even at a molecular or immunological level, how the body responds differently.
Okay, so what does this all mean then, wrapping up? We've
Yeah.
journeyed from, the early days of wide open heart surgery to these incredibly precise, minimally invasive techniques being used today, all guided by the sources you shared.
It's been quite a transformation.
We've seen how procedures for pretty much everything, coronary bypass, valve repair and replacement, aortic surgery, even treating AFib and implanting LVADs are becoming less invasive. And this often leads to faster recovery, less pain, better cosmetic results for many patients. That's highlighted by studies showing those shorter hospital stays, reduced blood loss, lower infection rates compared to the traditional sternotomy.
Definitely clear benefits there. But as we discussed, we also heard about the trade-offs.
Yeah, the flip side.
Potentially longer procedure times in the OR, like cross-clamp and bypass times. Challenges like complications from peripheral cannulation, and that steep learning curve for surgeons adopting these techniques.
And the future, as these sources suggest, is really being shaped by exciting technologies, advanced robotics offering that incredible vision and control,
Yeah, enhancing capabilities.
and the promising integration of virtual and augmented reality, maybe for better planning and guidance down the line.
Plus the potential impact of AI and maybe even bioprinting further out.
So while minimally invasive cardiac surgery has definitely gained significant ground and offers some really compelling advantages,
It certainly has.
traditional methods do remain the benchmark for now, and ongoing research, especially those big randomized controlled trials, is just critical to fully understand the long-term benefits and the risks involved.
Couldn't agree more. We need that solid evidence base.
Oh, this brings us to an important question, something for you, our listener, to consider. As technology continues to shrink incisions even further and enhance surgeons' capabilities, how might our entire perception of recovery and quality of life actually change after major heart procedures?
That's interesting.
What possibilities really open up when the path to healing becomes less about overcoming major physical trauma and maybe more about incredibly fine-tuned, precise intervention?